I'd like to introduce everyone to today's speaker, Ralph Llewellyn. He is a healthcare partner with Eide Bailly in Fargo, North Dakota. Ralph has over 20 years of experience in the healthcare industry in the areas of finance, leadership, reimbursement, and operations. He began his healthcare career as a hospital CFO for a 49-bed hospital with a 116-bed nursing home. For the last 16 years, Ralph has been with Eide Bailly, where he is currently the Director for Critical Access Hospitals. He assists providers with the development of solutions in the areas of cost report reimbursement, charge master development, billing compliance, operations leadership, organizational structure, process flow, board education, licensure status, and EHR incentives. Ralph is a frequent speaker at state, regional, and national conferences, and he is the past president of the North Dakota chapter of Healthcare Financial Management Association. So now I'll turn it over to you, Ralph, to share your presentation.
Okay, thank you. I appreciate the opportunity to get to visit with you. Fortunately for you guys are in a much warmer climate than I am in North Dakota today, so hopefully that is treating you well. The topic of today is CAH financial management, improving performance in the hospital setting. And as we look at that, what we're going to talk about today is those things that I see, that we've seen as a firm and as a group, as we work with facilities around the country. And, you know, when we look back at when CAHs first got their status, I think a lot of people thought, well, you know, there's a lot of additional dollars there now. You know, success is going to be a lot easier. But at the end of the day, financial success is still not guaranteed, and it's definitely not easy, as there's been so many other changes in the healthcare arena since critical access hospitals came into play in 1997. As we look at long-term success, and we look at those facilities that are making it versus those that are struggling, there seems to come down two different factors. One is location, and the second is the development of best practices. And obviously, to this point, no one has figured out how to change the location of your organization. However, as we start looking at best practices, those are things that can be addressed by all providers. And what we find is a varying amounts of success in implementing strategies and practices, sometimes that are easy, sometimes that are difficult, but at the end of the day are things that everybody can pretty much do in their organizations to make sure that you're capturing those reimbursement dollars you have coming to you, and at the same time hopefully controlling the expenditures that you're incurring as an organization. As we look at today's agenda, we're going to talk about 5 different areas. We're going to talk a lot about revenue recognition, because there's a lot of facilities doing a lot of work that they're not collecting for. Talks about some benchmarking, issues with physicians, follow up with some issues on overhead allocations in critical access hospitals, and then talk about other services throughout the organization. In the area of revenue recognition, one of the challenges that we find as we're working with providers is seeing organizations that are doing a lot of work, the nursing are doing the work, the physicians are doing the work, but then for some reason or another, the processes aren't in place to make sure that we're capturing those revenues. And this isn't always just an issue with small critical access hospitals. This can also be an issue at times with PPS hospitals. When we look at the emergency room, this is just a very common area where we see some significant charge capture issues. And when we look at it, there's really 3 different things we're looking at. We're looking at the E&M, or the evaluation and management levels, charges, as well as procedures that are being reported. The first piece, as we look at the evaluation and management codes, this is a challenge for providers because Medicare basically has said that when you look at the CPT codes 99281 to 99285, that each facility has its own ability to develop a methodology to assign those different levels, and that these resources, or the levels, had to be assigned based off of resources that were utilized by the facility. Now, this rule came out, or this guidance came out, back in 2000, and it coincided with the time when the OPPS, or the Outpatient Prospective Payment System, was coming out for the PPS hospitals, but the rule on the levels still pertains for critical access hospitals. Now, when they came out with this rule, they basically said, you get to develop your piece or your methodology, but we don't have any guidance for you yet because really the CPT code books don't really talk about hospital resources. They talk about physician resources. And they said, don't worry, in a year or so, we'll get you some information on this, and we'll give you some guidance. And they kind of kicked the ball down um, about every year until about 2006, and then they kind of gave up and said, you know what, we really just don't have a way to give you a better tool than what you probably already have. So as we look at facilities, most of them have the methodologies that they had back in 2000. And for those of you that are familiar with the ER area, you typically hear of these about point systems. So many points and you get to certain levels. Well, a lot of these were developed early on when there was little guidance even outside of CMS. And what we find a lot of times is that there's a lot of items that are included in the point systems that should be separately billed. So if we include them in the point systems, we may be inappropriately overstating an E&M, or we may be missing a separately billable service. And then the other thing that we find is that there's really no rhyme or reason as to how many points got to each level. So we find varying distributions of services at each of the individual facilities as we work with them. Here's an example of a curve of the E&M levels 1 through 5 for a facility that we worked with. Medicare has said that nationally they would expect the distribution to be more like a bell curve. Now, obviously, each facility is going to be able to have a little bit of differences because each facility is going to have a little bit more severe or a little less severe types of cases. One of the flaws that we run into oftentimes is facilities believing that as a critical access hospital, their curve really should be veering to the left. Well, big facilities also, big city facilities, also take care of a lot of lesser intense services, just like critical access hospitals. Critical access hospitals, a lot of times you're along highways, you're in farming communities where there's farm accidents, manufacturing. There's a lot of severe things that you're taking care of also. What facilities need to do is go back and look at what is their distribution, what is their bell curve. Does it make sense for us as an organization? I've seen some organizations where it's not even a curve, it's a straight line. Almost everything's ones or twos, and then it goes down from there. Going back and looking at where you're at in that area. So the best performing facilities have went back, looked at their distribution, made sure that it makes sense. They've also made sure that they don't have separately billable procedures in those points to get to the levels. As an example, lacerations or an IV, you can't use those actions or activities to get you to a higher level. Now, as you go through this process, what the best performing facilities find out is that while in the past it maybe took 0 to 25 points to get to a level 1, 26 to 50 to get to a level 2, there was really no science or magic behind that 25 points. Maybe it needed to be 15. So going back and re-looking at their distribution, the services that give them points, to make sure that going forward, they're capturing the right revenue. So if you take the facility we talked about here, where you have the bell off to the left, you go back and you fix it, what you'll find is once you've fixed it, you'll find more of a bell curve that would be more natural. Again, every facility is going to be a little bit different. But when you look at the difference there, here's an example of a smaller facility. And obviously some of you are going to go, this isn't a lot of volume for us. Some of you are going to say it's a lot of volume. This is a facility that had about 5,000 visits to their ER. When we looked at their original volume to their new volume as they fixed their curve and we looked at the charge, this ended up showing them an improvement in gross charges of about $260,000. Now, we'll talk a little later about net revenue because that's the money you get to spend, but $260,000 for fixing the E&M levels, that's not an uncommon number to be found. So as you look at that there in this organization, that was a 23% increase in reimbursement just because they were stepping back and reevaluating their E&M levels. The next piece that we run into, and this one's becoming a more difficult thing to talk about because of all the things we hear on the news and everything about, how expensive things are in facilities. One of the things we have found, though, is that when you look in relation to critical access hospitals versus PPS hospitals, critical access hospitals frequently are still charging substantially less than their PPS counterparts for the exact same service. And when I talk about the same service, I mean, you're either doing the same E&M level, you're doing the same procedure. I came from a small which is now a critical access hospital. When you got a service from us, it was the same quality. One could argue better because of the personal attention, but yet it was difficult to get prices up to what the bigger facilities were charging. And there's a lot of reasons why that happens when we're in the rural setting as to why we don't have our prices as high as others. Sometimes it's a restraint put on the management or by the board. And oftentimes what I found there, or do find still, is that the board doesn't want to do a price increase of 4 or 5%, even though they're increasing salaries, they're paying more for supplies. They're volunteers, they don't want to deal with the complaints on the street, so they hold those back. And with the argument that we've got to be less expensive than the bigger cities, even though the other businesses in our towns, our smaller towns, their prices are typically going to be at or above. The other part is a lack of understanding on the reimbursement impact. We have seen a big increase in the gap between PPS and CAH charges since 1997. Prior to that, when critical access hospitals were PPS, they were doing overall a better job of keeping up with the market, trying to keep their prices in line. So there wasn't as big of a gap. But what we find now is while the big hospitals for years have been running at 8, 9, sometimes 10% price increases, critical access hospitals are running at 2, 3% price increases. And if you take that differential over 4 or 5 times, it's not very difficult to find yourself in a situation where you can be 30, 40% below the market for the same services. And then the last piece that is a real challenge is just the inability to access market data. And as we go through the rest of the discussion here on pricing, I'll tell you there's no perfect data out there, but there's better data than not having anything. As we look at successful facilities, what they're looking at is market-based data, either commercial sources or MedPAR. Commercial sources you have to watch because oftentimes I find them to be very limited in the amount of volume they have, as well as the parts of the country that they actually have good relevant data. MedPAR, that's the outpatient claims data that is sent to Medicare by all of us as individual facilities. That is by far, in my opinion, probably the best methodology out there now. It provides you good information for all outpatient services because they have the CPT code, they have the average pricing. It can give you a good idea of what your market around you is charging for these services. And when we talk about market, we're typically talking those larger facilities that they go to if they bypass your facility or if they're price shopping. Most often, as we look at that, we look at facilities, the best performing, are trying to get somewhere close to the 75th percentile. A lot of them will go somewhere halfway in between the 50th and the 75th. But they really stay away from the 50th because the average facility out there is struggling. They don't want to benchmark themselves to that component. The other piece is annual price updates. Some of your contracts allow you a certain amount of increases to commercial payers each year. You don't want to give up a year without an increase because you can never make that up. And it's hard to make up when you start finding yourself 20, 30% behind because it's just a mathematical quandary to how do you catch up over time or do you do it all at one time. So in that same facility we looked at before with the bell curve, here was looking at their charges compared to the market. And now as you look at these original charges, these may be substantially different than what you see in your organizations because every market's different. But as you can look at as they went through and looked at their pricing, they were actually a little high in level 1. They were low in levels 2 through 5. As they went through and looked at the potential of increasing those charges, there was almost $600,000 of additional revenue just by getting their prices in line with what would be expected to be charged in other facilities. That's another 42% increase in pricing. And when I find facilities that are behind in pricing, these kinds of numbers don't surprise me. Sometimes they are only 10% and 15%, but 10 and 15 adds up too. But definitely there are opportunities for the organization to identify some additional revenue opportunities for the work that's already been done. And then the last piece is don't forget the procedures. When we talk about people inappropriately including things in the E&M levels, sometimes because they've been included in there, staff that don't understand how reimbursement works, that you can get reimbursed sometimes on CPT codes, they believe since it was built into the E&M level, we're going to get paid for it. And so there's some belief that they capture it there, or the fact that they put the CPT codes on the claim, even though there weren't additional charges, they may get some of the captured revenue. But at the end of the day, you really need to make sure that you're separately billing for all of those procedures in the ER. And we find all kinds of reasons why it happens, including the ones I've already given. The other one is sometimes we'll hear that, well, the physician said we can't bill for that because he did the laceration repair, we didn't. Well, your charge isn't for actually doing it, it's for your resources, the nursing, the supplies, that component around it that needs to be reported. So when we look at the average charge on one of these procedures, if they're missed, those charges can be $50 to $1,000 a piece. They probably average somewhere around $100 to $200, and typically probably 20, 25, 30% of those patients would have a separately billable procedure if it was captured. And this reimbursement can be based off of charges, percentage of charges, fee schedules, any of those. So as long as you capture it, you should be able to capture the additional reimbursement. Now, when we get to Medicare, we know it's cost reimbursement. There isn't any necessary additional cost, so we won't get any more money there. But not just Medicare and Medicaid uses our ER. We have other payers. So an example with the 5,000 annual visits, if 25% of them had an extra charge, average charge of $150, that's another $187,000 of revenue. You start looking at this and adding that all up, in this organization, that was over $1 million of additional gross revenue. And they had about a 60% non-Medicare volume because ERs are used by everybody. And they were getting about 75 cents on the dollar for their charges. That's over almost $500,000 of additional reimbursement. So definitely some opportunity for organizations to look at capturing additional dollars for the services that have already been rendered. Charge capture becomes an issue not just in the ER area. We find it in virtually any area that has outpatient nursing services, as well as the other one that's been surprising as of late is we've seen some significant increases in the areas of loss reimbursement in the area of pharmacy. So outpatient services, what we're talking about there is IV therapies, injections, Foley catheters. It can be anything that you do, thinking of like something you do when you have an observation patient in, somebody in the ER, somebody in the OR, somebody that's in for blood administration, chemotherapy. It's all of those areas where we see significant errors. And again, this is not just an item you'd see with critical access hospitals. It is a PPS issue also. When we do audits of claims, outpatient claims, we find that somewhere between 30 and 40% of all claims that go out the door have an error. Most often missing a charge, most often a charge that would have a CPT code or a HCPCS code that would be separately payable. Best performing facilities still probably have 10% of their claims going out, missing something that if properly captured would be an additional reimbursement to the organization. When we look at this here, there's lots of reasons why this happens. Most of the time, it's poor processes. We don't have processes in place to help everybody understand what needs to be captured, what needs to be reported. So as an example, infusions and injections. Commonly, we find that HIM or nursing, depending on who's generating the charges, are missing a lot of capturable charges because nursing documentation doesn't support what was done. They don't have the proper start times, stop times, the site, the drugs, the order of the drugs, how many different sites you have going on. All of those are very key and important in making sure that you capture the right amount of revenue. And again, this is not just a CAH, this is a big PPS issue. So it's something you really want to focus on. What can we do to capture that reimbursement? Best performing facilities have two departments that really become the drivers in this. One is the DON, and the other one is HIM. The director of nursing, the responsibility there, the charge there is that nursing has to document it. It's a concentrated effort to make sure that we're documenting everything we do. With its infusions, etc., we have all of the start, stop times, all that. If it's lacerations, it's the length, the depth, the location. It's all of those components so that when HIM comes in on the back side of it, they can capture the charges and capture the reimbursement. I can't tell you how many times when I'm on site, we're working with providers, we see that they've done an extended infusion therapy, but the lack of documentation has resulted in them only being able to bill a 15-minute IV push. Significant reimbursement differences within that. So definitely an area that as we see people doing better or worse, an opportunity for organizations to step up, capture some additional reimbursement. Pharmacy was the one that actually really came in as a surprise, and it's two things. We see either charges are totally missing or they're reporting the incorrect number of units. And as we look at the why behind this, there's a couple of things. One is that as we've seen organizations purchasing more of the Omnicels, the Pyxis, these dispensing units, they're sometimes, I think, sold with the idea that they're the solution for charge capture. And they can be. If properly utilized, they can capture all your charges as you're dispensing the drugs. However, what we find is that it only takes about 15 seconds for staff to figure out how to circumvent the security around the dispensing and charging of the drugs. And so they're more in tune as taking care of the patient, not so much on the charges, and we tend to find significant amounts of charges falling through the cracks. And sometimes I've even seen it in areas where they've got heavy chemo expenses, where those are being missed. Those can be significant dollars and cents in the organization. So if you have those systems, I highly recommend you go back, do your audits, look at the medical record versus the charges to make sure that you're capturing them. Another easy way to find it is going back and looking at claims. If you're seeing that you've got injections being charged but no drugs, probably a good sign that something's getting missed. The other thing is the units. And what we mean by the units is that as you dispense a drug and you report them on the outpatient side, many payers pay you based off of the HCPCS code. Unfortunately, the HCPCS code rarely equates to the dosage that you actually get to render. So let's say the HCPCS code says this is a 25 milligram drug, but you give a 50 milligram dose because that's the only way you buy it, that's the only way it's dispensed. When you report that, you have to report 2 units. And a lot of systems got those set up early on when those rules changed to do that, but it doesn't seem like there's a lot of follow-up to make sure that those systems are maintained. So you really want to go back, look at that opportunity, see if there's some opportunity to pick up some additional dollars and cents. Timely filing, we capture all the charges and then we don't get them filed on time. Through the audit side of our practice, we still run into organizations where they're not getting their Medicare claims in on time. We have a 1-year turnaround. Why are we not getting the claims in there? What's the process? A couple of things. One is monitored write-offs. You should have a separate account where you require your staff to put those write-offs, because oftentimes they get hidden in contractual allowances, and CEOs and CFOs don't even know how much is being written off because of timely filing. So you want that separate account. The danger that we're running into is that Medicare has a 1 year. We have commercial payers that have 90 days now. And I can tell you that just recently, I was working with a provider in California. The contract that they received from a payer said 30 days, which isn't possible because of things in lab as far as cultures and things like that. And we were able to get it pushed back out to 90 days. But the story is that it's getting shorter. And we got to make sure if we're doing the work, we're capturing the revenue. Now we got to get the bill out so we can get the cash in the door. Denials management. In a time when we're struggling financially, it's still amazing the amount of facilities that are not properly issuing and following up with advanced beneficiary notices. You need to be managing these denials, following, making sure you understand how much money you're losing due to denials. It used to be that all these denials came in the area of lab, and lab charges aren't as high as maybe some other departments sometimes, so it didn't seem like maybe we were losing as much. But now we're starting to see issues in imaging. And if you miss a CT scan or an MRI or something, the dollars there are quite significant. And so the message that the more successful facilities have sent to their staff is that ABNs are not an option. Now, we got to look at how do we deliver that message. First and foremost, the majority of facilities that struggle with ABNs struggle because somewhere along the line, somebody used it as a messaging technique about the determination of proper care. This is not a determination if the physician has ordered the right tests or not. What this is it's an issue of who's going to pay the bill. And that's what we need to have in place so that we can capture the revenues from that perspective. Track the denials. Most often what we'll find is if you track it by the type of service, the physician, and the staff performing the service, you can identify where your breakdowns are in your processes. Sometimes there's breakdowns because the organization has no process at all. Others, it's because we have a process, but somebody is not following it. And then we need to work on that person, bringing them back into the fold, holding accountability so we can capture those dollars and cents. The other thing to watch is the emergency room. Emergency room services are not exempt from monitoring denials. Now, one could say, I'm not going to issue an ABN in the emergency room, and I can understand that and I can respect that. But that doesn't mean that we just say that it's a free rein. What we want to look at there is we want to monitor on the back end what type of denials are we getting in the emergency room. Is it one physician? Is it one type of service? Is there something we can do in discussions after the fact to change practice patterns? Probably the most common thing I see there when we see significant write-offs due to medical necessity in the ER is it's CT scans, and it's one or two ER physicians that are ordering an abundance of CT scans that are being denied. And then it just becomes an issue of education, working together to see what can be done to resolve. Pre-collection efforts. Pre-collection is getting to be a larger and larger issue all the time. Back when I was a hospital CFO 17 years ago, trying to do pre-collection would get your name all over the paper and all the coffee shops and everything because no one did it. But that was back when deductibles were much lower. When I started as a hospital CFO, they had just went from a $25 deductible to $250, and people thought it was the end of the world. Now we have $3,000, $6,000 deductibles. Some of the people on the exchanges will have as much as $13,000 deductible as a family. So pre-collection is becoming extremely important, much more than it ever has been, because if you think about it, at this time of the year, right now, in January, with everybody on their newer plans, if they've got new plans, or they're starting the new plan year, the majority of the cash you have coming in today could very easily be coming out of the pockets of individuals and not out of insurance companies. So we don't have those big checks showing up every week, every 2 weeks from the commercial companies. We're having to find it from the individuals. So pre-collection definitely needs to be in place. Strong facilities really have that down. And one of the things they find is that patient satisfaction also improves as you develop a good pre-collection effort, because one of the stressors that people report is not knowing what the bill is, that anxiety, etc. If they know what's going on from the very beginning, they may not like the dollar amount, but they have an understanding of what their obligation is. It's not the fear and as much anxiety. So we need to be collecting a time of scheduling, time of service, basing it on estimates if necessary. I have some providers that if you come in through the ER and you don't have your insurance cards, etc., they know this is X number of dollars is what we require, obviously after they've done their EMTALA. If it's a CT, if you don't have specific information, they know the CTs run about X dollars, and they do an estimate off of that. The other thing with pre-collection efforts is you can really improve your ability of identifying charity care early on, because you can do charity care either through an application or you can use presumptive methods. Some of the presumptive methods I think are amazing. They're scary. They're very big brotherish, but they can identify as you're putting in somebody's information an idea of what the size of the family is, an estimated annual income, and basically kick out if they appear to qualify for your charity care. You can get them into financial counseling right away, and you don't spend time on the back end trying to chase an account for which you should have or could have known that there wouldn't be a reimbursement opportunity for your organization. Now, I'm not trying to advocate writing off more charges than we should be, but I also don't want to see us spending time chasing things that we know we're never going to get any money from. Benchmarking. I've seen more facilities in the area of critical access in the last couple of years with all reform and all those discussions coming out, really looking at benchmarking. And again, this is another area where there isn't perfect data, but there's data that can give you a good direction and sense of where you need to be going as an organization. There's two types of benchmarking you can use. You can use external data, which comes from outside groups or organizations, as well as we can talk about internal. Now, when we look at external, it can provide the greatest benefit, but it's the hardest to find. You can get peer facilities at times. If you do have external benchmarks, what we recommend you do is look at that 75th percentile. And the reason being is you want to be in the top quartile. If we look at the average facility, critical access hospital or other, they're all struggling. We had a facility years ago that called us and they said, well, we've got our statewide numbers and we're right at average. We're right at average on all of our benchmarks and we're losing money. And my question was, well, how's the average facility in your state doing? Well, they're losing money. And that's because that's what we benchmark to. We need to benchmark to that higher end, that higher percentile, so we can perform better. And then we have to do our best to understand the benchmark and the methodology of how they gathered the statistic. There'll always be some questions, but again, this gives us the direction. And finally, the hardest data to get. Internal benchmarks can also work very well. And we have a lot of facilities that do look at using internal benchmarks because it allows them to benchmark themselves over time. And they can start following trends and seeing what were good years versus what were years that were not as good to identify what's changing in our organization. So if you're going to look at a internal benchmarking, typically you want to look at something around 5 years because that gives you a nice gamut of time to look at something as far as department by department. And then you can start using that also to help provide solutions and to reduce resistance from departments when you say we need to do something different. Because you can show them back to a past time that, hey, you know what, we were able to do better before. What's changed? So as an example, in an organization here, where this was actually one where they looked at utilizing both external benchmarks as well as internal. And so the review of the department basically said in 2011, the hours per statistics was 13. And you were over the benchmark because the benchmark out there on the external data says 10. So really, as you look at this, you need a 23% reduction in the staffing in this department to get you to where that benchmark would be. And I'm a finance person, as I'm assuming a lot of you are. When we lay that out, we don't usually get the best responses from the clinical folks, and they'll say things like, patients will die, quality of care, when's the last time you took care of a patient? all of those things, which are valid questions. When we do benchmark studies, we have RNs that work with us, so they can help combat some of that. But it's still always that question. But when you have trending information, historical data, you can take data and you can go back and look, gee, what was so different in 2009? Because based on the benchmark and the story that patients will die, we must have injured a lot of patients in 2009. What happened? We went from 9.8, we jumped to 12.2, we're now at 13. Not only have we increased, but we are showing an annual increase in the number of hours it's taking to take care of these patients. What has changed? Is it a department head? Is it different staff? Is it some breakdown in some process in the organization, so we can find out where that breakdown was? Because one of the interesting things is that we find is if you could get all of your departments to operate at or near their best productivity over a 5-year period, there would be significant improvement in financial performance. And you're not going to get all of them to meet those benchmarks every month, but if you can get the majority of them, there are significant opportunities. And one of the things we hear in critical access hospitals, and again, I was in a small hospital, is that all my departments are core staff. We're all core staff. We can't do it with anything less. We don't always find that. We'll have departments saying, well, this is the minimum number of people we need to run it, and we'll run the hours, and we'll say, yeah, if you actually ran that number, you'd be at the benchmark. But here's what you're actually running. And then it gets into the how are we managing those hours. So lots of opportunities in the area of benchmarking, et cetera. Physicians are always an ongoing challenge. As we look at the years that I've been in healthcare, more and more facilities are employing or contracting. Couple of challenges there. First of all, many of them fail to align their relationship, setting it up as they bring physicians on to make sure that they all have the same end game in mind. So integration does not equal alignment. You may be paying their salaries and everything else, but are you all working together, working at the same direction, etc. The other part of it that we run in is that a lot of us didn't run clinics before. That's not our expertise. And so we fail to manage it because we don't understand it. So a couple of things. One is losses are expected, and that's hard for a CFO to say. Clinics typically lose money. And now we've got to start talking about what is our strategies. So when we look at losses, I think about it when we bring in physicians, we date them, we court them, we bring them in, and the first month when their clinic loses money, we give them a financial statement and say, you've got to fix this. You got to perform harder, you got to work harder, etc. Even though we probably should have known or did know that they were going to lose money every month. Good facilities determine or calculate what's that tolerable loss. Again, another hard word for a CFO type. How much loss are we anticipating from the very beginning and managing from that? If we lose less than what we anticipated, those would be celebrations. If we lose more, that's what we're managing to. And it's working with the team, the physicians, get everybody on board is what's that tolerable amount? What is workable? What are we going to manage to? It sets a whole different tone in the organization and in the relationship between administration and physician groups when you're managing to what's something that's realistic and can be anticipated. So as we look at strategies, what can we do to fix things in that area? A lot of times because we don't understand clinics that well, when we look at our better performing facilities, they understand them. They utilize benchmarks. They know how many nursing staff they should have per provider. They know how many people they should have in the registration area per provider and such so that they can manage those numbers to an appropriate level. And then the other thing is making sure that they've all explored all of the alternative reimbursement methodologies. I still have a lot of providers that have freestanding clinics that we run into. Why aren't you a rural health clinic? Why are you not a provider-based clinic? What are your options out there to improve that reimbursement dollar amount? And then when you find that option, make sure you manage it. Rural health clinics are a great opportunity to improve the reimbursement of the organization. However, when I look at RHCs and I look at them from a cost report and we look at them from a management perspective, we find significant flaws in the reporting and handling that cost them sometimes tens of thousands, in larger RHCs, hundreds of thousands of dollars in reimbursement dollars. So a couple of things we need to know. One is that everybody needs to understand what's an RHC visit. An RHC visit, a billable visit to Medicare, is something that happens in the clinic, homes, nursing homes, swing bed, scene of an accident. The most commonly missed one is swing bed. A lot of rural health clinics are still billing swing bed as a non-RHC on a 1500. And the reason that has happened is because prior to 2005, that was the CMS interpretation. They silently changed that interpretation in 2005 when they fixed the whole SNF PPS consolidated billing issue with rural health clinics. They changed their tune on that and said, no, swing beds are like nursing homes. They are an RHC visit, but they really didn't send any dissemination of information out. So that was an issue. It also has to be a medically necessary face-to-face visit. And there's separate with a mid-level or physician. And there's certain areas that need to understand this in your organization. The billing office needs to know this. They can't send a bill to Medicare if it's just a nurse-only visit in the RHC, not to Medicare. Most business offices understand that piece. Where the problem comes in is on the cost report side. At the end of the year, as the cost report's being prepared, somebody asks for the number of visits. They just go find a schedule, pull off the number of visits, give it to the preparer, and unfortunately they include things that are not RHC visits, such as nurse-onlys. They may include ER, outpatient, inpatient. This area, the number is frequently overstated, which means you end up getting a lower cost per visit calculation, and you lose reimbursement dollars. Every facility should be scrubbing that. If you do your own cost report, you have somebody externally looking at it, you want to scrub that to make sure you're getting the dollars and cents. The other thing is, we're under a misconception at times that we get paid cost in the rural health clinic. We get 80% cost, 20% charge is the way the calculation works. So charges are important in the RHC. It's important that we keep our charge level competitive in the market. Don't let it fall behind, because every dollar that we fail to put on that claim to a Medicare beneficiary, we do lose 20% of that dollar forever. We don't get that back on a cost report. So next one, provider-based clinics. These aren't the rural health clinics, but the provider-based. Don't be afraid of them, but you really need to make sure if you're looking at doing these that you give the proper time to set them up and get them working appropriately from a billing perspective. Again, good opportunity for improved reimbursement, but a lot of facilities are leaving money on the table. Strategies, compensation. Still running into a lot of facilities that are still paying guarantees over time. I understand guarantees getting somebody up and running, but at some point in time you got to get the right incentives so everybody's going in the same direction. You know, looking at a transition period to relative value units. But at the same time, as you go to production, you also need to make sure that you're paying them or rewarding them for the other things that you need them to do and want them to do. You know, sometimes we'll hear people say, oh, you know, I can't get my physician to do anything related to his medical directorship, you know, position. And I say, well, how do you compensate them? Well, all their compensation is based on RVUs. Well, that's probably part of why you don't get what you need, because they're seeing that as something that's being done for free. So as you look at your total package, breaking out those things for directorships, supervision of mid-levels, any other administrative levels, ER coverage, definitely want to make sure you're capturing those. And there's some really neat ways to do that to incentivize them to be doing what you want them and need them to be doing. Overhead allocations on the critical access side, you know, you can only get paid right if you're allocating right. And as I start this discussion, one thing I will tell you is that if you report everything right on the cost report, it's not so much that you can make money, but if you don't get it right, you could lose a lot of money. So you want to make sure you haven't been losing any money through missing opportunities for better statistics and overhead allocation methodologies. So it comes down to accuracy of the statistic as well as the appropriateness of the methodology. A lot of times when we meet with department heads, they don't understand what the statistics are being used for. They don't understand why they're measuring square footage. They don't understand why they're keeping track of their time for housekeeping. They don't know why they're keeping track of laundry pounds. I can't tell you the number of times when we've done staff education with those department leaders and help them understand how their data is used, the light bulbs that go on. And they're like, oh, my data probably wasn't as accurate as it could have been. And if I made it more accurate, we may have an opportunity for better reimbursement. The other thing is making sure you have the right methodologies. A lot of facilities looked at this initially when they became CAH, but then haven't looked at it periodically since then. Facilities have changed. We've added things, we've deleted things, we've got new buildings. Periodically, we need to relook at that. The most opportunities that we find, the common areas, fragmenting of administrative and general costs. Instead of allocating it based on accumulated cost across the board, it's looking at, can we allocate business office differently? Can we look at registration and admitting differently? IT, others. I have some facilities that have actually broken their business office into two business offices, one that takes care of hospital, one that takes care of the nursing home, home health, et cetera, where they might be able to get better allocation of overhead. To better, and in all reality, the better allocation reimbursement comes at the same time that you're typically improving the accuracy of it. Looking at housekeeping, time studies versus square footage, medical records, looking at gross revenue versus time studies, all kinds of opportunities to be looking at that. Best practice facilities are probably relooking at their overhead allocations every third year, just to make sure that they haven't missed something. They'll do it sooner if something kicks in as far as a change in their building, et cetera. Then finally, other services. This is one area that as we look at critical access hospitals across the country, those that have less other services tend to be those that have better bottom lines. So when we look at home health, hospice, freestanding physicians, ambulance, nursing homes, assisted living, et cetera, many of us are in those because we don't have an option. And that I understand. But sometimes there's options for us not to be the one that's providing those. And the Medicare cost report does us absolutely no favors in the allocation of costs when we have these, because it tends to take and push overheads over to there versus the hospital that would otherwise be reimbursed under the Medicare methodology. The other challenge that we sometimes have is that with all those costs being allocated over, the reimbursement model in some of those services just is not appropriate for smaller organizations. Home health, hospice, and some of our smaller communities, the reimbursement model isn't as such that it really is something that we can make money as a critical access hospital running them. We can't even break even sometimes as we do that. The other piece is that, and this is kind of even going back to my days as a provider, rural providers often sometimes don't have the management time, because running a hospital, managing physicians, those two roles alone may take the vast majority of a CEO, a COO, a CFO's time. They don't have time to spend on home health, hospice, dialysis, maybe some of these other smaller services. And they may not have the commitment time, expertise, whatever. What we have found is that our more successful facilities are looking at, how do we pass these out to another entity? We still need to make sure that they're probably provided in the community, but maybe we don't have to be the one that's shouldering that. So home health is a very common one. It's interesting is I've seen these sold from a CAH off to another entity. Staffing levels tend to improve overnight. They're focused on managing it because they got to run it in a smaller business focus. They start working on how do they better schedule their visits, all of their running around, all their downtime, all of that is managed much better. The other thing is that oftentimes those services, they may be getting higher compensation than what they would be if they were freestanding, because we pay everybody hospital nursing rates versus the rates that we'd see, which would typically be lower in a home health or a hospice or in one of the other services. The compensation is different. Sometimes it's benefits, but definitely you can bring that down. One exception is the 340B program. The retail portion of that program can be a significant exception from that. We've seen facilities where their net reimbursement numbers that are in exceed $1 million. We actually have one we've been talking to recently. It's looking at $2 million a year. Over 200,000 is common even for small facilities. Now, the one thing you do have to note, and this is not a common piece out there that has been discussed, but the MACs, the Medicare audit contractors, have indicated that you can't ignore this on the cost report. There is some costs you're incurring that's going to most likely end up in a non-reimbursable cost center if you follow Medicare rules, and it's going to take some A&G allocations away. It'll offset some of the benefit. It won't negate it. We just want providers to make sure they understand what piece is there. So as we look at this in kind of closing, what we've talked about today, those are the types of things that we see the successful organizations focusing on. It's not just focusing on, but it's really the accountability side of saying, we're not going to be missing charges. There's no excuses for that. Our pricing is going to be right. We are going to be, reviewing our cost reports. We are going to have positive relationships in contracts with our physicians that work for both sides. We're going to manage all those components. These strategies, they're not the only strategies in the world, but they are the most common ones that we see differentiate the average struggling provider from that one that is performing extremely well. Obviously, again, location can have a lot to do with it. We can't change that, but we can implement best practices, and these best practices can help us turn some financial performance around. So with that, Leslie, I'll turn it back to you. Questions?
Does anybody have any questions for Ralph? It is *2 to unmute your phone line. And while we're waiting for questions, I just wanted to point out in our monthly Delta Dispatch newsletter, we also highlighted on the importance of focusing on revenue cycle and also the pre-collection, just due to the amount of people who signed up for insurance through the exchanges. And like you mentioned, the very high deductibles that they're going to be paying out of pocket, especially at the beginning of the year. And if nobody has any questions, I did want to point out we have a couple of resources on critical access hospital finance at the center. We have one that was developed in 2012, and it was from a financial leadership summit that we held with our critical access hospital finance leaders and experts. And Ralph participated in that meeting, and we have a summary posted on our website that includes the top financial indicators that can be used by hospitals to benchmark. I'll post a link to that in the chat box. And we had one other resource as well that was just recently updated, and it was a Critical Access Hospital Finance 101 manual. And that one is basics on critical access hospital finance, and it includes frequently asked questions, which is a good resource to share with your board and also staff members at your hospital. So I'll post a link to that one as well in the chat box. And Ralph did share his contact information, so if you have any questions later on, feel free to contact him. And if you are interested, Ralph is presenting another webinar on Friday on PPS, Hospital Financial Management. And the playback of today's webinar will be available on our Help Webinar Playback page on our website. And if you would like to receive a CAH Qualified Education credit for today's webinar, you do need to complete the online evaluation and indicate that in question number 2. And the link to the SurveyMonkey evaluation is on the screen as well. So thank you, Ralph, for presenting today. And thanks to everybody else
have a great day.
for taking the time to participate.